Well, welcome back to the Paindora Podcast. I'm Dr. Melissa Cady, joined by Dr. Kevin Cuccaro, as we say Dr. Kevin. And we are going to start off today's talk about something I just started mentioning to Dr. Kevin that I really want to do for pain professionals, especially pain medicine physicians out there. But there's some real dilemmas and struggles, despite the fact that a lot of pain medicine physicians have more time and maybe could learn about different ways of looking at pain, and especially because they can't do or deliver what they've been traditionally trained to do, which is injections, spinal cord stimulator implantations or trials, or pain pump placements, or whatever it is, or giving opioids. That drives most of the business, and the infrastructure to keep the business alive is to do things to patients and make money from those things that they do to patients, which does not usually lend itself to a lot of time to spend with patients to discuss pain science, or at least embed the information of pain science into their story and what they're going through. I guess my first thought is, or maybe I'll ask you, Dr. Kevin, directly, is what is the current challenges with, maybe if I had a platform online in a Facebook group to share this with them, what do you think the struggles or hurdles are for that?
Okay, just a couple of clarifications, just because who knows when people are going to be watching this video.
Right.
We're in the middle of the COVID-19 pandemic. At this moment in time, which is early April, most people are at stay at home. So all quote unquote non-essential sort of health and healthcare has sort of come to a halt. And we talked about that earlier, how it's remarkable an entire system. The whole economic foundation for the U.S. healthcare system is designed on doing stuff that people don't really need to them, because you're seeing that. And so what you were referring to in the statement was with pain doctors having more time. And the reason is those are what we would call non-essential services. So all these injections and things outside of the data and evidence, which we talked about previously, people aren't doing them because it's a risk. It's a certified health risk at this point in time. So there's this time when you have a bunch of people who are not doing these busy poke practices or injection practices, or anybody who's not doing a very busy practice because you can't see patients in your clinic. So here's a perfect opportunity to learn.
Mm-hmm.
So I just want to put that out there.
Clarification, by the way.
Well, and I only did that is because I'm
no, it's good.
Who knows, is the internet, someone will be watching this years later, and there's going to be some important stuff that we're going to talk about that is going to be relevant outside of this pandemic.
Right.
And so we are having this discussion, how do we kind of introduce this stuff? Because if you're looking at healthcare transformation and you want to transform the system, it can't just be me, and it can't be just you, and it can't be the 3, 4, 5, 6, even 10 or 15 other people that we know. Mm-hmm. Right? To have widespread change, you need to have concepts adopted of good practice that are rooted in the science rather than myth, so that and there needs to be some really exponential growth so that you can actually transform a system of healthcare. Mm-hmm. And good on you, because you were thinking that way. and here I am. I think it's really, really hard. And I think it's really, really hard, even in the scenario where you have practices with no income coming in, to get them to adopt these principles and practices and change the model of how they're delivering care and talking pain and working with their patients, and going from this entrapment, passive modality model where it's all due to them, not about what they can do themselves, disempowering the patient, doing all this stuff. The problem with even trying to educate in this scenario is that there's nothing to replace that income stream with. Meaning, sure, you can go out and say, well, you can do telemedicine, but if you look at the reimbursement rates for telemedicine, they're not even close to what you would get for, say, even an epidural steroid injection. And it is so much easier to walk into a room, or even, the horrible way to do it is people then line up a bunch of telehealth visits and then start talking to them, and then start pushing out and say, well, when the stay-at-home order goes away, we're going to have our schedules full. We'll make sure that you're in the front of the line for this procedure, or this procedure, or this procedure, right? And this it just comes back to kind of this human nature thing, where if you tell people not to do, first of all, if you say, don't do this, but you don't replace this with something else, the likelihood that someone's going to follow through with that is low. Because in the default in the stress scenario, you're going to do whatever the course of action is that you're used to doing. That's just the way the brain kind of works under stress. Yeah. You makes it even worse, though, if I have an incentive to do this that you're telling me not to now do, and I haven't replaced it with something else.
Right.
So, the problem with the pain world is that the incentives to practice good care and to empower your patients are not there.
Right.
There's simply no, and this is going to sound so awful, folks, but it's like the God honest truth. There's no incentive. In fact, you're disincentivized to do the right thing for your patients. You're disincentivized to learn up-to-date pain science. Because it's not aligned with the typical healthcare environment. So that's a very, very long way to say is here's this perfect opportunity when people who may have been so busy working and having such busy practice and putting as many people through these assembly lines, and those assembly lines have stopped, and there's a chance for them to learn, but the likelihood of that actually happening is very, very low.
Yeah. Well, and I think that there's this idea of even if that one pain physician that normally was doing injections and giving opioids, if they happen to be open enough to listen to, say, a webinar we put together regarding how you can help patients transform their pain via telemedicine, if they were open to that, they would have to struggle with how to deliver that in a conversation with a patient who's had a completely different belief system, who's been basically, you're trying to change a belief system in a physician who then has to try to change a belief system that they're struggling with their own patients, and their patients believe that they need something done to them. And so I don't feel like there's a lot of people willing to endure that kind of challenge. And I feel like there has to be a certain level of, I don't know if you want to call it persistence, stubbornness, a level of moral or ethical standards that you just can't live in any other way than what seems like the right way. Granted, those physicians out there probably believe that everything that they're doing is ethically and morally sound because that's the basis of their training and how their belief system is. But when you try to shift your belief system into something else, it really, you and I have both gone through it and had an enormous amount of struggle, anxiety, and pain that goes with shifting a belief system that takes away the money that would provide for your family. So I think it's not just on the level of the physician or the clinician, it's also when they redirect it to the patient.
Well, and that becomes, that's a challenging interaction as well, right? Particularly if it's somebody you've been seeing for a significant amount of time and you've done a bunch of stuff too, because there's a huge mea culpa that comes along with that. Because they're going to say, well, why did you do this to me? Yeah. And, and granted, they all don't, not everybody will say that, but you have to be prepared for that conversation. Yeah. And the way that I've explained it to people I've worked with, like the clinicians, because I work mostly with clinicians, is if you're coming from a place of if it's a true mea culpa and your change is for the right reasons, people have a tendency to understand a little bit more. And if you have a connection with the patient, meaning that they're someone that you've enjoyed working with and you have that therapeutic, or you just have that relationship, it's scary to do the first couple of times, but as you get better at it, it becomes less scary, and it's usually not as scary as we make it out to be.
Yeah. Can you define mea culpa?
Mea culpa is like a fault, my fault, right? And actually, what I should do is pull up the actual Latin for mea culpa. Let me do that just so I make sure I don't.
we're getting a little bit of a lesson here on words.
Yeah. So an acknowledgement of one's fault or error. The only reason I want to do that is because language is a big deal to me, and I always want to make sure that. So the Latin itself is through my fault, which I think fits absolutely perfectly. Because through my fault, I've done this to you. So it's a full acknowledgement of your responsibility in this interaction. And when you're looking, particularly in healthcare and specifically in a pain world, there's a lot of mea culpas that we're doing, because most of what is out there. So because you're talking about that, we not only have to shift the beliefs of the practitioner, but then we have to work on someone who a person who's been living in pain for sometimes decades or years. We have to start working with their belief system, but that person's belief system was significantly influenced by us and our actions.
Yeah.
And and you know, that's a whole different conversation. That's a conversation we should be having, because of what we've done in this world with the pandemic, as you call it. I don't see us being the pain physicians per se on a level and scale of the mea culpas that we should be doing. Because we complain about this problem and this whole idea with the opioid epidemic, which is the symptom of the pain epidemic. And it kind of makes me, I'm going to go off on a little tangent here, but it makes me angry, because you'll see the pain specialists, the opioids, blah, 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 blah. We did that.
Yeah.
We did that. And yeah, pharma was involved in it, but we're the ones who said the words. We're the ones who told people lies. We're the ones who listened to this stuff. You know, because we're originally, I'm sure it was when you were being trained. When I was in training, we were telling people that if you had chronic pain, persistent pain, the risks of addictions were low. You were actually less likely to get addicted to opioids than if you actually didn't have persistent pain. And that's completely false. It was based on no data and a host of other reasons. But we've done, you know, the reason that people are seeking all these injections is because we're offering them, giving them, and promoting them. The reason that we have so many back surgeries in the United States is because we're offering, we're doing, and we're pushing people to them.
Called marketing and sales.
Marketing and sales. So we have a lot of mea culpas, and to pull it back to the beginning of this, I don't know if we're the profession who's the right one to do, who's going to be the ones that change. To be honest, I am not convinced that pain specialists, the specialty of pain medicine. First of all, I don't think it necessarily needs to exist. And number two, I don't think we're the ones that are going to cause or create change.
Yeah, it's kind of a harsh reality that I don't I don't think a lot of our you know, pain trained colleagues, I don't think they really want to hear that at all. I wanted to make a comment that it's kind of ironic. Last night I was watching a TV show that had to do with a lot of mafia related drugs and how, you know, this whole there was a bad batch, it affected them and people died. And, you know, I made a comment to my husband and I was like, you know, the whole reason when I finished my pain fellowship, I literally had 2 days after my training, within 6 months of my training being done, that I had written prescriptions at a clinic I was helping out at. And I just got sick inside just thinking that I'm putting this stuff out there and I don't know how it's going to affect people. And I told my husband last night, I was like, that's the biggest reason I couldn't go forward, is that I just felt like I was contributing to something I had no control over, and that it was a slippery slope. And I'm not, I mean, heck, I do anesthesia part-time. I'll get back to it eventually, whenever I can do elective cases again. But I don't have a problem using opioids in the right way, where I have control over that and it's not going to be abused, or, you know, even mindful of people who had addictive pasts and try to modify my anesthesia plan. You know, those things I really take into account. But for this chronic persistent pain issue, I just didn't have, I couldn't even stomach it to be able to do something like that, because I felt like it was going to become what, you know, like I always say, and you mentioned, is the pandemic. And I feel like we did contribute to that, and I didn't want to contribute to that. And when you have hundreds of thousands of physicians doing that, it doesn't surprise me. It's like a lot of us saw this coming, you know, without the numbers starting to hit, without the public knowing. We knew somewhere deep in our being that we were putting stuff out there, and if we're really honest with ourselves, it was going to cause a big, massive problem.
Well, and the only thing I would add with that, well, couple different things I would add with that is if you could track the negative outcomes to all the procedures that we were doing, and they were as evident as extreme, and they were being picked up by people in the ER and law enforcement, which is the entire reason the so-called, the opioid epidemic was even called out. We didn't call it out.
Right.
It was called out because of law enforcement going, who are all these people and why are they coming in? And then the emergency department when they're having all these people with overdose and issues. So it wasn't even the pain specialist calling the stuff out.
Yeah.
But if we could track back the outcomes that have happened with our other therapies with relatively no or low or negative evidence associated with them, all the procedures, I think we would have a whole different conversation along that. Because if you actually look at the data for opioids for persistent pain is awful. But it's actually a greater body and probably better than the data we have on interventional procedures and surgery, which is absolutely shocking. I mean,
right.
It's bad.
Yeah. Well, can I say a point to that?
Yeah.
Within my book, I had only one chapter talking about opioids. I had looked at some of the reviews on Amazon, and there was one person in particular or a couple people felt like I kept hammering at opioids, and I kept thinking about, it's like, how is it that people are thinking when I have one chapter on it, and the whole book, it might relate or connect to opioids, but how is it they felt like I was overemphasizing it? But I realized, the community at large, society at large, has been inundated with all this opioid and overdoses and all that. But the whole definition of pandemic is that it's overutilization of opioids, injections, and surgeries. But the data, like you said, it's not overtly being, told to all the people in society. They don't have a conceptualization of the impact. And what we said earlier, to tie it into it, is we're creating a belief that they need these things. But if you look at graphs of looking at over 5 to 10 years of the number of opioids, number of admissions for overdoses, the injection rates, the epidural use, the surgical rates, even looking at fusions for back pain, all of those are rising, but there's no concomitant decrease in pain rates at all. In fact, it's quite the opposite. The pain's getting worse despite the overutilization of all those things. And what people don't see is the injection complications, the surgical complications, deaths that come from some of these things. So I just wanted to reemphasize that, because I wholeheartedly agree that people don't recognize it. It goes way beyond opioids.
Well, and that comes in the mea culpa though too, is because even with all this attention, like I've gotten a reputation that I'm anti-opioid.
Yeah.
And people have written some really nasty things about me because of some of the stuff on it, but I'm not anti-opioid, and I'm opioid for where it makes sense when you understand pain. And you already touched on this. It makes sense when you're in an area where you have a large peripheral nociceptive component, blah, 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 which is to, mostly perioperative or acute trauma or something like that. It's remarkable to me because we've all these task forces, and even at the national level. So as this stuff was getting, opioids were getting all this press. People in our specialty who were supposed to be sitting on these national task force were recommending crap. They're like, we don't prescribe, or we need to cut the prescription, and you know how to do it in this way, blah, blah, blah. And you can use interventional modalities as an adjunct. And it's like, you can't say that you're doing evidence, that you're supporting some sort of evidence-based document to target the opioid epidemic, and then insert crap in there that you have no evidence that it doesn't have any evidence to support it either. And so, and the only reason you would do that, at least in my book, is because there's a personal gain, right? And we're talking about that belief system again. Which comes again back to the mea culpa, which goes back to the original point of this conversation is, if you're going to change the system, trying to change with a group of people who have the highest invested in the current model, in investment, meaning really the highest financial gain from it, because that's, when you're financially incentivized to do stuff, the data says you will more likely do it. So the more that you have invested in a current paradigm that's supported by financial incentives, the less likely you are to change. Yeah. Even in an opportunity that we have right now where people's clinics are shut down. So the question then becomes is who should we be targeting, right?
Right.
Who should we be targeting with this?
Right. Well, I mean, the pay structure has to change in order for, if, you know, as you said, people could question the need for pain medicine, physicians like ourselves. At least the numbers that we have out there is way beyond what we need, especially when I hear people are doing anywhere from 20 to 50 injections a day. That's just absurd. If there's a payment restructuring on if people actually got paid equally to someone who did an epidural injection, which won't happen, I sincerely doubt, unless someone has a cash practice that people are valuing that person in particular and has been sold or word of mouth or whatnot. But if you can talk to a patient and spend the time with them and review things, reassure them, educate them, support them, give them skills and things that they can do to help themselves, you know, maneuvering through their pain journey. If you got paid the same as someone doing an epidural, you know, then it might shift things, or you just don't pay for it. You block any reimbursement for doing those things. That's the only way I see somebody. I mean, it's probably going to dissolve practices, but you can see a lot of fighting for those reimbursements within small communities. I see that they're trying to fight in a political way to make sure that they get reimbursed for the things that really aren't supported well in the evidence.
Well, that's universal. The medicine is universal.
Sure. But definitely within the pain physicians as well.
In the pain physicians pain and spine are the worst.
Yeah. They're trying to hold on.
The absolute worst. And then, but because they have so much money, they're also an extraordinarily potent lobby. If you look at the spine surgery lobby, who makes even more than the interventional pain specialist,
the irony.
It is ridiculous what they're doing. Like from the political lobbying. So, but then okay, let's go back to how do you change the system? And I always kind of like to distinguish what I call the circles of control. There's the circle you control, which is your thoughts, your behaviors, your actions. And there's the external circle, which you don't have control over. And so we always want to, and granted, I've bashed my head against this wall for years now, but you want to change the system, right? You're like, how? I want to change how this stuff is getting paid. And that is insane. Like even you start like even trying to do that and having done this at the state level or tried to do that at the state level, you get all these hype, you know, because these people and their lawyers come in and basically first they present garbage evidence and then they're garbage evidence and they refute that. And then they say, well, you were biased. You as whoever is the one on these committees that are looking at the payment methodologies. So then they start attacking people for saying that they're biased without any, and you can't question them. It's like, well, who's paying you? And how do you get paid? You get paid to do all this stuff and you're calling us biased? And then the third thing that they do, if that doesn't work, is they start looking at the actual, the procedure. And whether every I was dotted or T was crossed, and then they threaten litigation through that. So, I mean, from a system standpoint, the roadblocks there are absolutely profound. Mm-hmm. So should we stop? No, you know, if you're crazy and you want to hurt yourself, you know, we do it. But what do we do actually have control over then is we have control over what we do, what you do, what I do, what our, you know, colleagues that are, you know, at least cognizant and aware of the science and trying to align with that practice. But then we need to look for the audiences that have something to gain.
Yeah.
Right. And we started off camera here, say like physical therapy. So not all physical therapy has some advantages because they have some of the best, some fantastic educators and some of the best researchers. And anybody who's ever seen me talk in any time knows that people like Lorimer Moseley are like, he's like one of my heroes. Like he's a unbelievable research scientist. He's a phenomenal educator. He's humble. You know, I have more interaction with him. So I know David Butler is another good one, but they have these people that are just like in the pain world, at the top of the peak. Now in the physician world, nobody listens to them because they don't have an MD or a DO or whatever after the name.
Which is a shame.
Which is a shame. I mean, these guys know way more than 99.999% of pain specialists out there. They know more pain about them. On the flip side, though, I also say because they don't have the MD or DO after the name, they're not a non-physician. Sometimes they don't understand what's happening in the physician world, so they don't push as hard as they should because they're just, I think they give them a way bigger benefit of the doubt than they should be giving them a benefit of the doubt.
Yeah.
But anyway, so PT's got all these people, but even in PT, there's a war about, because you have to fight against the group of people who are in the do camp. And the do camp is profitable. So we're talking trigger point injections. We're talking manipulation, even other passive modalities like the ultrasound. I mean, there's people who will advocate against it, but it's so much easier to do something. And it feels so cool. Oh, it's my magic hands. I mean, we're DOs. We know what it feels. Oh, yeah, my magic hands are doing magical things. I feel so good, except when it doesn't work, and then it's the patient's fault. And so there's a war there. Now the audience that, so they, some of them have something to go, and then they kind of freak out because they think they're going to have to be psychologists or whatever. But there's an audience out there that I think has huge potential, and that would be behavioral health. Behavioral health being psychology, social work, LMFTs, licensed marriage and family therapists, because they don't have it doesn't hurt them to provide good pain care. In fact, it becomes a gain because they're already seeing people who've been put through the ringer. Like after everything else has been said and done, it's like, well, go see your behavioral health or mental health specialist, and they're going to tell you how to cope with this, right? Or as a psychologist friend of mine said, who had an interest in pain and then got driven away from pain and now is totally back into it, with his pain understanding and just is in fire again. He's like, I didn't know what to do when people were put through all this stuff, would have surgeries, injections, gone through PT 100 times. And then they're telling me, they said, there's nothing else that's going to be done for your pain. Go to the psychologist because you need to get so they can help you with your depression. And he's like, I would look at these charts and see these people with what would have been done and how much pain they're in. And I'm like, well, how am I supposed to tell them not to be depressed or work with them on the depression? I would be depressed if this was me, right? And it's this model then that the pain somehow is fixed and then you have to work on the depression. Now that obviously changed when you understand pain, and you can see how that complex interplay is and how depression is involved in the construction of pain. Now we can treat the depression, and lo and behold, we can actually improve the pain. But they have no disincentives to learning this other than years of being again, the typical biomechanical thinking about pain, that there's nothing they can do for the pain. They can only help the anxiety or the depression, rather than I can help the anxiety, I can help the depression, I can help the PTSD, and through that help someone's pain. So if we can spread that message,
right?
Yeah, and then the importance of behavioral health overall, like if the more we can start engaging behavioral health in the healthcare system, so that we're not saying, a 5-minute visit and then saying, well, you have you're 20 pounds overweight and you have high blood pressure. Let's start you on a blood pressure pill. Instead, you're saying you're 20 pounds overweight. We have an opportunity here. Let me get engaged with behavioral health specialists so that we can start, teaching you skills, and we're going to coach you through this so that you can go out and you change your diet and exercise and get healthier that way. Because if you lose 10 pounds and we can hold it off, that has the effect of a blood pressure medication. So you do that, you'll never have to be on a blood pressure pill, or we would hope not. But you need a behavioral health specialist there. So then if we're targeting that group of people and we're giving them the pain skills in addition to the other skills that they already have, and we're entwining this stuff together, so it's no longer the specialty of pain, which is completely nonsense. Because if you're in healthcare, you're going to see somebody with pain. So everybody should be pain literate. Empower these group of people, though, who have the knowledge and skills about behavioral aspects and can provide that long-term kind of facilitated change. That's where we're going to see change. That's where we're going to see system transformation, if we can get the incentives aligned.
Yeah, that's brilliant.
A little bit better there, just a little teeny bit better there.
Yeah, so then maybe, the struggle with trying to get pain clinicians themselves to learn how to help transform pain in their patients via telemedicine should be more like, here's a educational thing we can do to help your supportive staff who provides either some kind of behavioral medicine, psychologists, social workers, whatnot, so that they can support the patients in your practice, and it'll be accessible to you as well. So maybe a few people would learn a few things.
And people are doing that. There is some evidence of that out there. The problem I have with that is you get these two kind of tracks of care. And the other part about it is it causes an incongruent message in the same clinic.
Yes.
And it's really, really hard for those clinicians, those pain literate clinicians who are working in a pain illiterate environment.
Which is what we dealt with when we had struggle.
But you're trying to, and you don't want to badmouth your colleagues or anything.
No, it's hard.
So it's really, really, really difficult to do. What we've kind of done locally here with some of the people I work with and their programs is they've actually stopped accepting referrals. They're like, and they've talked to the primary care docs and then say, if you're going to send them to the pain clinic, don't send them to our program.
Wow.
And because the reason is it's going to waste their time and it's going to waste our time because we're going to hear completely different messages from these different environments. And what we know is the message is extraordinarily important. So, and they'll say, well, let them do whatever, which always makes me feel horrible because these people are getting sent off and having bad stuff done to them. But they're like, they can come back later. My preference would be as if we can shift everybody down that route. Let's just get rid of the pain clinic that's really an injection clinic and filter them into the programs first, and then the people who are really struggling in those that need a little bit more, maybe one-on-one, then we build out the resources there.
So maybe pain medicine clinics should be called nociceptive medicine, nociception medicine clinics.
Well, that would be your regional service, right?
Yeah.
So you don't need a pain clinic is just an injection clinic. So to me, honestly, if it's a persistent pain phenomenon, then the pain clinic should be staffed by behavioral health specialists. Period. Because they have the skill set for it. Maybe you need a movement specialist so that you can make them feel comfortable and decrease the fear associated with movement again. No, for the injections, because then now people say you're anti-injection, Dr. Cuccaro. I'm not anti-injection either. I'm an anesthesiologist by training. I love doing injections, but you got to do them for the right reasons.
Right.
And so that becomes perioperative care or an acute care setting where now you're doing rib blocks for people who have rib fractures, and maybe you're trying to get them off the vent. Maybe you're doing
it's an acute pain service.
It's an acute pain service, or that would be your acute nociceptive service. Even those people, though, should be pain literate. Because I tell people now, it's because people are like, well, you want to shift it out. Well, the acute and the chronic. And we know that for the chronic, we're not going to write opioids and blah, 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 but the acute pain is easy, which is nonsense. The fact of the matter is, if you understand pain, if someone has all that, what I would call heat and oxygen, so lots of anxiety, depression, past trauma, early life stressors, and they break their leg, yes, you may want to do a regional technique, but you're going to want to address those other issues as well. How can I help this person feel safe? How can I smooth out their expectations of what's occurring with them? How can I prep them to have a successful recovery? How can I follow with them and make sure that they know that someone is with them, that they're not being abandoned or thrown out after a single visit? Yeah. So how can we care that therapeutic encounter through it with them? And the only way you do that, though, is if you actually understand pain and you realize it isn't about a simple block the pain pus deal, but say, hey, we're going to block that nociceptive input. But I have someone who's scared. Maybe they don't know. They've never been in a hospital system before. Maybe they had a bad experience in the hospital before. And it changes the way you practice. And then we would actually see, I hope we would actually see, we see this change downstream. Because now if you're addressing that acute issue off the bat in a pain literate manner, we can interrupt that kind of cascade that kind of presents to persistent phenomena where now people are living in pain for decades and decades and decades. If we can shorten that, that'd be fantastic.
Yeah. No, there's, the whole idea of trying to get, I know we started out with how can we, or what are the challenges with trying to educate our pain colleagues on better ways of, educating their own patients on how to transform their pain. But I think we've shifted to recognizing that there are a lot of components and issues at hand, and sometimes, and for us, it's difficult dealing with our own colleagues. It's not just some other person that's trying to educate, but our own, like for ourselves who've been trained at the same level. Trying to get them to change their mind is so incredibly difficult. And you and I have been doing this for years, and we feel like it's like going uphill on ice, and it's just, you can't really make the impact that you really want to make. But I do think, as you said, that we're shifting to recognizing that we have to reach out to people that it makes the most sense, and change the payment structure on what people are being rewarded for doing, so that the people, the end user, the patient, actually benefits the most. So any last thoughts on these challenges of trying to educate pain clinicians or changing the pain system? I mean, you've hit a lot of stuff, but
I think the last thoughts is we need a body of people who are willing to stand up to the highly invested side, right? Because the people it's a very difficult and challenging process. But when you are, again, changing those financial incentives, the amount of I don't know what the word that you the people against you.
mm-hmm.
We need more and more people who are willing to stand up to that lobbying body.
Mm-hmm.
And I do think that comes actually from confidence in understanding pain, because the people right now who are trying to change those systems, almost none of them come from a pain background, meaning they don't know what we know. So they don't actually know the details about how these procedures are done. And so when you don't understand it, there's this mysticism, and you're like, oh, maybe they're actually doing something, even though the data says nothing. Maybe even they say that the data doesn't say anything, but I know just through my personal anecdotal practice that these injections work, which is not how you're supposed to practice medicine. They're usually not aggressive enough. And there needs to be enough people, because frankly, I don't have the strength to do it. Like the few times I've been up there by myself,
It's so hard.
It is. It's unbelievably. You say a couple of things and then you just get overwhelmed because you're the lone guy or a lone woman standing up there. So we need a cadre of people that are actually willing to stand up for what the data and evidence says. Because when we start working on those financial incentives, and it's going to happen because not only may have accelerated that process now with COVID, with the way these financial systems or these healthcare systems are falling apart as it is. But we need to have physicians and other healthcare providers who are willing to say the right things for the right reasons, to change those financial incentives.
Yes,
it's hard.
Yeah. So anyone listening, if you're a clinician that wants to rally with some people like us, or you're a patient or somebody that is, seeking pain care, that wants, has found somebody that thinks more in line with how we think, or not just think, but stand by the pain science, and have changed our practice because of what we see to be, more effective for people who have pain. You can always share what we're doing on this podcast and the YouTube channel or podcast, in whichever venue you're listening to it. But I think that we're kind of spread out, and so it's going to take us reaching out and connecting.
But thank God for the internet.
That's right.
Because when it's just you and you by yourself, you think you're going absolutely nuts. So
yes,
you're not nuts. The world is nuts, and the internet is here, and we can connect to everybody. So, anyway,
that's right.
Are we done now? Is this?
I think so. I think people have heard enough on this topic.
I think so. But I just want to emphasize, though, this is super important.
Mm-hmm.
And the problem is there's so much screaming, and there's so much yelling on all sides, and there's a lot of fear on all sides, and there's a lot of passion on all sides. So it becomes very, very difficult to have like a useful conversation. And I don't want anybody, the ultimate goal, particularly what we're talking about here, is we want to help people get better, because we know it's possible. So even the people who don't think it's possible for them, who have been put through the ringer, who've been told all this stuff. I mean, we have such great examples now of people who, I mean, my favorite is Mo, who's a local woman here who's had pain for over 60 plus years and now is living she calls it her perfect, magical life, right? So her pain started when she was 14. It's possible. And so we're not advocating, we're not trying to take away therapies. We're not trying to take away things. What we're trying to do is align everything so that people can get the care that they need, so they can get the solutions and outcomes that they want, which I am assuming is get back to your families, doing the things that you enjoy, living a full life again, rather than being kind of trapped in pain and being told that the only thing that you can do is now manage it. So people get mad and they get upset with some of the stuff that we may be talking about, but we're not trying to hurt anybody. We're actually trying to help people help themselves to get well, because it's possible.
Yeah. And just a clarification, Mo is someone who is a patient of somebody else that has publicly acknowledged and shared her story on multiple occasions. So this is not an infringement on patient class.
No, I've got a recording with her at Straight Shot Health. So if you want, I have a whole podcast.
I watched it.
And she won't stop. She's blah, 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 blah.
Maybe we should throw a link on that for this podcast.
She's fantastic. I just love her to death.
That's awesome.
Anyway.
So enthusiastic.
Yeah. Well, I guess that's the end of this particular one. And for everybody out there, thank you for tuning in to the Paindora Podcast. We appreciate your support. And again, we can change this. We can change things. We can help people get well. If you're interested in contacting either Dr. Cady or I, we should have some contact information on the links here. And until next time, stay well.
Bye-bye.